The first amongst these is an online pachymetry. Now, intraoperative and online pachymetry helps us determine the pre-op pachymetry, that's the pre-op corneal thickness. It lets us know what the actual flap thickness is, what is the stromal bed available for ablation, and what is the stromal bed at the end of that, that is the residual stromal bed. Now, why do an intraoperative online pachymetry? The flap thickness, especially with microkeratome flaps, as Sujata also has described, has a lot of variation, and this variation can result in unsafe results, especially if we have a very thick flap in a thin cornea. So what we did is, we did a study where we found that out of 250 eyes of 130 patients with the Moria M2, we found that the intended flap thickness for a 130 micron flap was anything between 115 to 152. The variation was quite a bit. In case of a one-use SBK flap, where we had planned a 90 micron flap, we achieved anything between 78 to 110 microns. Now, it is this variability in the flap thickness which is so important, so that it's so crucial, because in case we have a thicker flap, we may leave behind a lesser residual stromal bed. So the Wavelight EX500 has an OCLR based interferometer based online pachymeter, which helps us to take the pachymetric readings in real time. Now, this can be done before, during, and after the ablation. This is a small video of how the procedure is done. Basically, you take the pre-op flap. After you lift the flap, the pre-op pachymetry, after you lift the flap, you repeat the pachymetry again, and it straight away shows you what is the flap thickness. You don't need to do that little bit of subtraction. And following the laser ablation, you once again take the flap thickness so that you know what is the residual stromal bed which you are left behind. So, what are the modifications? How do we use this tool to help us achieve better results? Now, in case of thick flaps, where we have got a flap thicker than what we had intended, now we would leave a residual stromal bed at our centers of about 280 microns. So, in case we get a thicker flap, we can either decrease the optical zone, we can do an undercorrection, or we can, if it's a small cylinder, we can try and omit the cylinder so that the residual stromal bed is maintained. In case we get very thin flaps, for example, if the flap is thinner than the 280 microns, we can increase the optical zone if required to match the pupillometry, which we had not planned initially. We can give a full correction in case we had pre-planned an undercorrection. So here are a few cases which we would like to discuss. The first is a case where a refractive error of -10 diopters, the pachymetry was 530 microns. Our intended flap thickness here was 90 microns. The planned optic zone 6.5 and the planned residual stromal bed was 280 microns. Now what we achieved was a flap thickness of 105 microns. And in this case, if we had gone ahead with our original settings, we would have left behind a residual stromal bed of only 265 microns. So what we could do in such a case was we decreased the optic zone from 6.5 to 6 millimeters, thus leaving behind a 295 micron flap residual stromal bed, which was within the safe zone. In the second case, with a refractive error of -7 diopters, the pachymetry, pre-op pachymetry of 502 microns, we had planned a flap of about 110 microns and an optic zone of 6.5 with a residual stromal bed of 280 microns. Now what we actually achieved was a flap thickness as high as only a 10 micron more, but this would have again gone below the 280 microns which we had planned. So here what we did is we just changed the target refraction from -7 to -6.25 diopters, leaving the patient undercorrected by 0.75 diopters, but achieving the 280 microns flap what we wanted, the residual stromal bed what we wanted. In this third particular case where we had planned a -6 diopter refractive correction LASIK, a PACHY pre-op was 502 microns, the intended flap thickness here was 130 microns. So after having seen all this, we'd achieved that the planned RSB would be 304 microns. Now what we here achieved was a flap thickness of 110 microns. So now, since we had a more residual stromal bed, we could change this optic zone from 6.5 to 6, from 6 to 6.5, so that it could match the pupillometry which we had done pre-op. So the other benefits of the online pachymetry is that you can document the residual stromal bed, and which is very important in case when you are planning enhancements, as well as in case of medical legal cases, so that in case you have a problem later, you know that what the actual stromal bed was left behind. So in conclusion, intraoperative online non-contact pachymetry is a useful tool in perfect real-time planning of ablation depth, optical zone, leaving of safe residual stromal bed, and thus increasing the safety and the predictability of LASIK surgery and customizing each and every case. The second part of my talk today would be on a pupil centroid shift compensation, which is achieved with the newer wavelight machines. Now, shift in the pupillary center along the X and the Y axis with pupillary diameter variations can occur between time and lighting conditions of the pre-op diagnostics, that is the topolizer or the oculizer, and when the treatment is finally done after the flap creation under the excimer laser. Now, why compensate for the pupillary centroid shift? Now, we found that in about 142 patients, 283 eyes which we studied, the shift of the pupil centroid was more than 0.2 millimeters in 88% of the cases. Now, what is done in pupil centroid shift compensation is the topolizer is connected via a local network to the excimer laser. It captures a 2D image of the anterior segment while the eye fixates at the center of the placidose disc. Now, the reflection of the center of the placidose disc over here, it locates the intercept of the keratoscopic axis and the cornea, that is a corneal reflex. Now, recognition of the pupillary edge is very important, as the pupillary margin is detected by the eye tracker and is used as a landmark to center the treatment. The pupillary diameter measured here is obtained with the illuminated placidose disc, and therefore it is the photopic pupil diameter. The pupil is delineated on this picture, and the projection of the center of the entrance pupil, that is the pupillary centroid on the cornea, locates the corneal sighting center, which is the intercept of the line of sight with the corneal surface. The image of the iris details are also captured here, and this allows to prevent the cyclotorsion prevention. The distance of the corneal reflex from the apex is then calculated. So if the apex is the center of the Cartesian domain, the X and the Y coordinates of the pupillary center at the time of registration can thus be computed. Now, in this particular example, due to a very large angle kappa, we have a pupillary center at registration with the topolizer is about 410 microns temporally and 60 microns inferior to the apex. Now, depending on the deviation between the pupillary axis and the visual axis as the angle kappa, the location of the treatment can be adjusted. The location of the treatment can be either at the pupillary center, or it can be at about 10% difference, 10% point variation between the pupillary center and the apex. So this is a small video of how this particular pupillary centroid shift compensation is achieved. The goal here is to initially match the entire iris diameter of the diagnostics versus what is seen on the excimer laser. So here is the picture which was on the diagnostics. This is the picture on the excimer laser. So the initial matching is established that the diameter is common. This is followed by seeing that the pupillary size on diagnostics and the pupillary size under the excimer laser is matched. This is done by either decreasing or increasing the ambient light. So once that is achieved, the cyclotorsion is registered. If the cyclotorsion registered is more than 10 degrees, we need to repeat the procedure. Having done that, now we go to the angle kappa adjustments, where we can center the treatment at 10 degrees point anywhere between the apex and the center of the pupil. Again, here if this is more, the angle kappa is more than 100 microns, then we would probably repeat the whole procedure again. Once all these parameters are registered and all these offsets are made, then we can go ahead with a perfectly centered pupillary centroid. So effectively what happens is eventually you land up getting perfectly well-centered treatment, case after case in all the cases. So thus, this helps us add an extra dimension in customizing each and every patient to his pre-op diagnostics. So in conclusion, a pupillary centroid shift and cyclotorsion compensation along with angle kappa adjustments are excellent tools to achieve perfectly centralized excimer laser ablation, and it adds an extra facet in truly customizing each and every LASIK procedure. Thank you for your kind attention.